Good morning and welcome to a presentation on the introduction to peripheral blood stem cell transplantation. My name is Nikki Knightley and I'm the bone marrow transplant ACP. So what is a stem cell? I thought I'd take it right back to basics. A stem cell is the very, very immature baby cells that our bone marrow produces. And it's a very clever cell that can replicate itself, or it can differentiate and become many different types of cells. So it could be a red blood cell, it could be a platelet, it could be a neutrophil. So peripheral blood stem cell transplantation is a bit of a mouthful and we call it PBSCT for short, but what does it actually mean? And there are really two types of transplants that we talk about. So you may hear the term auto or autograft, or you may hear us talk about an allograft. If we start with the autografts, so an autograft, the way I remember this is it's U and it's got a U in it. But in essence, it's where patients receive their own stem cells back. So what happens is the stem cells are collected from the patient, they're processed in the lab, they're cryopreserved. The patient is given chemotherapy, and once they've had that chemotherapy, the stem cells are then reinfused to the patient. With an allograft transplant, what you're doing is you're giving the patient a donor's set of cells. So the donor will be identified, they will have their stem cells collected, they will be stored, the patient will undergo necessarily chemotherapy, and then the cells will be given to the patient. So in order to collect stem cells, there is a process that either the patient or the donor has to go through. Now, for an autograft, that process generally involves some kind of chemotherapy, but for a donor, they would not have chemo. But what they would both have, whether they be patient or donor, would be GCSF injections or filgrastim injections. And these injections are started on a specific day, which has been identified to be best in relation to their needs. They will commence those injections, and the aim of those injections is to stimulate those baby stem cells that are in the bone marrow to overpopulate and come out into the blood vessels. When the stem cells have done that, it then makes it easier for those cells to be collected on what we call an apheresis machine. And collection of stem cells can generally take anywhere between 1 and 3 days. If patients are really unlucky and they've had a lot of chemotherapy beforehand, it can take much longer than that. The stem cells are then taken to the laboratory and they're stored accordingly along with some preservative, and they're frozen. And they can be kept in the freezer for up to 5 years, and in some cases even longer. If we were going to use stem cells that have been stored for more than 5 years, then we would do a viability test to check that they're still viable for use. The patient then has chemotherapy, and then they would have their stem cells back, and this is what we call the stem cell transplant. There are lots of terms used for a stem cell transplant. You can hear bone marrow transplant, you could hear a stem cell rescue, or you could hear the more common term stem cell transplant. Once the patient has had the stem cells, whether that be a donor cell or their own, we will then wait for engraftment of those stem cells to repopulate and start to produce your white blood cells, red blood cells and platelets. Now, the patients we see on WUnit and primarily 3-day therapy are our autograft patients, and the process those patients go through is really broken down into 4 steps. So patients will be diagnosed and then they will undergo some form of chemotherapy. Now, in order to even consider a patient for transplant, there are a couple of things we need to make sure happens. They need to be responding to treatment. We can't give patients a transplant who are not responding to treatment. They also have to be fit. And those two things have to happen, and those things are reviewed when we first see the patient in transplant clinic. If patients are fit enough and they're responding nicely to chemotherapy, then we will arrange for priming chemotherapy and then a stem cell harvest. Now this may be done, the priming chemotherapy may be done as an outpatient on day therapy, or if it's a more complex regime, it would be done on Dove unit. All patients generally go to NHSBT in Oxford to collect their stem cells, and again that could be anywhere from 1 to 3 days. The next steps is then to plan and bring patients in for the stem cell transplant. And again, there's a couple of things that need to happen. Patients have to undergo a lot of baseline investigations to make sure they're fit, but they also have to have collected enough stem cells. And there are on rare occasions, but it is possible that we're unable to collect stem cells from a patient. And in these circumstances, patients would not be able to proceed to transplant. Patients then come into hospital and they undergo their stem cell transplant and generally spend about anywhere between 3 and 6 weeks in hospital, where they'll have high dose chemotherapy and their stem cells returned. And then we have to wait for those stem cells to recover. Once they're recovering and they're free of infections, then we will consider discharge and recovery at home. And recovery at home for an autograft patient can take anywhere between 3 and 6 months. And so it's really important that we make patients aware of this. So just to talk about those 4 sections in a bit more detail. Diagnosis and treatment. So the current diseases that are treated by autograft are multiple myeloma, which is our most common, relapsed chemosensitive high-grade non-Hodgkin's lymphoma. Now this is a change in landscape. Up until recently this was the case. However, at present, if patients are fit, they may be put forward for CAR T-cell therapy as opposed to an autograft. Relapsed Hodgkin's lymphoma patients, patients with mantle cell lymphoma, and again that is a change in landscape and those patients are more likely to go for CAR T-cell therapy at present. Patients who've got central nervous system lymphoma and those who've got plasma cell leukemia. And those pictures there just really show you some abnormalities of what cells would look like under a microscope if they had specific diseases. And the picture of the black blob in the middle, at the bottom in the middle, is what the white kind of matter in the middle of that picture is lymphoma within the central nervous system. Now, in order to harvest stem cells, I've talked about what the patient needs to have with regards to performance status and disease control, but we also need to ensure these things happen. Patients need adequate veins for collecting stem cells. They need to have a good vein on either side of their arm. And if they don't have this, then we need to consider whether we need to put in a apheresis line, which is a type of Hickman line. They also need to undergo some type of chemotherapy. They will then have numerous days of GCSF injections before the stem cells are collected. Admission to Dove unit happens for all of our stem cell transplants. In some occasions, patients may now be admitted to Oxford, and this is generally lymphoma patients. And the reason for that is we had numerous issues with Malphalan chemotherapy, and because patients have 6 days of chemo in a beam transplant, with Malphalan being the last day, we didn't want to run the risk of this being delayed. So at present, when this is being recorded, which is April 2024, patients are going to Oxford. However, we are in talks with them coming back to us. So if you're looking after a lymphoma patient, they may have been to Oxford and then been repatriated back to us, or they may have been admitted to us directly. Patients are given their high-dose chemotherapy, and then after a 24-hour rest period, they are generally given their stem cells back. This is known as day 0. It generally happens over 1 day, but there are circumstances when we give stem cells over 2 days. And the reason for this is if it's very difficult to collect stem cells, and we do this over numerous days, they're often in lots of bags. Each bag has a dose of preservative within it. If you give too much of that preservative to a patient in one go, you will cause complications and reactions. So therefore, to reduce the risk of that, we often split the reinfusion over several days. They will then restart GCSF on day 5, so that's approximately 5 days after they've had the stem cells. They'll remain an inpatient while we manage their side effects, and those side effects may be things like nausea, vomiting, mucositis, infection and diarrhoea. They will also be in protective isolation. And the reason for this is because their immune system is low. We want to try and minimise the risks that they're coming into contact with. And when we talk about discharge and recovery, as I've already mentioned, generally patients are in hospital 4 to 6 weeks, although it has been noted that those patients that collect a good number of stem cells and have a good dose of stem cells back seem to get out slightly quicker. So we have had patients be discharged around 3 weeks. And we aim for a neutrophil count of above 1 for more than 3 consecutive days. However, that's not the whole reason that patients can go home. They need to be infection-free. And sometimes patients will recover their neutrophils nicely, but then they will spike a temperature and develop an infection. And this is sometimes the body's reaction to what they've been through. Once patients are discharged from the ward, they'll have twice weekly reviews on the day unit, and they will generally fully recover within 3 to 6 months. Now, the landscape of treatment has changed quite dramatically in the last kind of 12 to 18 months. So for a myeloma patient, where that would be the end of their journey, that's no longer the case. They will now undergo a further 2 cycles of chemotherapy and then have maintenance oral chemotherapy too. So transplant is part of their journey, but it's not the conclusion of their journey. I hope that's given you a kind of brief overview of the transplant pathway. Obviously, the landscape is changing regularly, and we are proceeding with more and more new treatments, specifically CAR T-cell therapy, and also new generations of drugs that are coming out. And whilst autograft and allograft remains the kind of treatments of choice for the majority of patients, there will be more and more of our patients undergoing these newer treatments in the near future. If you have any questions about what has been discussed, then please don't hesitate to contact me.